So we've gotten to the end of the structured schedule. We have an hour of open time. If anybody has any questions, I'm not sure I'm looking online and I don't even see a thing. Oh, there's something popped up. So if there are any questions online, this is kind of an open forum. I mean, if there were issues you wish had been addressed that weren't addressed, we can all kind of pause here. I don't know, any in the room, any burning points to be made or questions to be asked? Yeah, Carol.
Hi. Can we use this forum to bring attention to CERT, community emergency response, and help that be well known throughout? I believe it started in LA, but it has become a federal program, and now is throughout California. And this is happening with the last storms or the fires. Actually, in Santa Cruz Mountains, actually we were displaced during that time, and in the storms. I think I spent 10 at night till 6 in the morning, helping people come in from just absolute torrential rains, right? So is this appropriate group to try to spread the word on joining CERT?
I think it sounds like the kind of program that it dovetails with what else is being developed. So
thank you.
Yeah, thank you for bringing it up.
I was just going to make a plea/request, encouragement to do more related to transition from pediatric to adult care. And some of it, I think, is just luck of the draw. At our institution about 7 or 8 years ago, I'm affiliated with Penn. They had no transition program, and it was virtually impossible to transition somebody, so we held onto our patients. And then by the good fortune of somebody's generosity, a former patient with ALS, they were able to get funds to be able to develop what's really a wonderful program. But that's not an expectation that I think many institutions can lean on or expect. But on the other side, I think there are examples of successful programs with adult neurologists, pulmonologists, cardiologists who have expertise, if not interest. And then more importantly, hearing the last two presenters talk about their own experience, really as I'd call them survivors, and figuring things out. That's another aspect of this that I don't think we as clinicians really understand, and it'd be wonderful to have that type of a resource for patients to rely on. Because I think the encouragement I sense from most of the advocacy organizations is at 18 or 21, you should transition your patients, which is virtually useless without better guidance. And in the cystic fibrosis world, that happens with money behind it, where the CF Foundation will say, if you don't transition your patients in a completely valid and comprehensive manner, we're not going to give you the X thousands of dollars to help you run your center. And so I don't know that that's something that we can really hope for, each advocacy organization merging resources and working together. But I think certainly leveraging some of the patient experience and adding that on to our own experience and ideas of what needs to be part of a transition, I think would be very helpful.
Yeah, no, I absolutely agree. And, on the other side, I mean, as an adult trained neurologist, I'm very aware that, we are not very well set up for pediatric onset diseases. I mean, we can accept them, we can, participate, but there's not the same connection to men with Duchenne that there is to boys with Duchenne. And I think that we need to do a much better job of coordinating that. So I think it's not just transferring care, it's transitioning care, you know, so that we actually maintain some sense of continuity of what's going on.
And from my understanding from my adult colleagues, it's transitioning to a different type of care where we have a wonderful multidisciplinary clinic, which I suspect many people have. But when it was suggested to my adult colleagues that they do the same thing, that was met with laughs because it's just simply not practical in the adult world.
Yeah, which is ironic because a lot of institutions have multidisciplinary ALS clinics, but they somehow have difficulty seeing that for these other disorders. So I think there's a lot of just kind of consciousness raising, if you will, on that side of the street that needs to happen. But again, it needs to be some kind of a transition. And I think that's really something we can probably address in upcoming years. I think it really is important. Any other? Yeah. Oh, thank you.
2 questions. I probably should have asked them when they were being discussed, but one is with the prenatal treatments for baby or for infants. What is the data on like the baby? Like we have a baby that was treated in utero and is presenting normally developing. They're only about 8 months old. So what should we expect?
So I'm curious. I'm sorry. So you're where? What?
I'm in Yolo County.
Okay.
And so this baby's in West Sacramento. And so.
And when you say was treated prenatally, that was.
I'm in utero.
Was treated in utero.
Yes.
With risdiplam?
So I don't know. I don't have those details.
It was
right now.
SMA.
SMA.
Patient with SMA.
And so they're being followed by an infant program, and we are monitoring them through our program. And so far they're meeting developmental milestones, and so we're like, what do we expect? And at this point we're like, are there other babies? What's the oldest baby that's been treated this way?
So I only know of one.
Okay.
I mean, and that was
that
a
might be-
patient treated at St. Jude.
Okay.
So I don't know about that baby you're talking about.
Okay.
We've looked into at Stanford. We've looked into doing because it's a matter of giving risdiplam to the mother, so that you can it would then get into the fetus. And we've looked into that, and we've not been able to make that work. Talking with our friends at Genentech and Roche, it's not simple. So I'm not sure.
Okay.
Do you know about this case? They don't want to stand up.
I'm like,
but we
uh-oh.
maybe this is one to discuss over wine. But
Like, am I opening up information that I'm or like?
we've dosed 2 babies within the first hours of birth. So because that we could get done. So we have one that was dosed at, I can't remember, 6 hours of life, and one that was dosed at 20 hours of life or something like that.
Yeah.
So that I have experience with, but treating by dosing the mom, we haven't done, and I'm looking around to see if any of my colleagues have done this. So.
Well, and again, this is the first time we've seen this, and so for us, we're like, oh my gosh, like this baby looks like a normal baby.
Yeah, the only thing that I can say is at St. Jude's, we've been asked to address all questions through Dr. Finkel and their group over there, since it's their data, their baby, and they have plans for the publications and presentations. So.
Okay, all right. Okay, well then the second question that I have is regarding, given that there's all the pulmonary concerns and this is kind of this case that we talked about with the child that had appeared to have like aspiration issues with eating, but was already eating. So then the plan would be to like do a swallow study and see what's happening. What are your recommendations, or what is your experience with kids with SMA who have been G-tube fed, whose parents are interested in getting them to eat by mouth or start trying things by mouth as they've, improved with their head control, things like that. Given their pulmonary concerns, given that they're on cough assists or they don't have strong coughs, and they haven't eaten by mouth, what are your recommendations for the families when they are trying to get enough down for a swallow study?
Yeah, that's a detailed question, and I know that we have, speech therapists and nutritionists and swallowing therapists that get very involved in these kinds of transitions. I think the overarching issues about bulbar function in SMA are well recognized as something that we need to do a better job of assessing and monitoring. But obviously, those are the questions you're posing. I would have trouble coming up with a simple answer to, but I'm looking around the room for someone who is going to bail me out here. But I'm not seeing anybody jumping into the fray. So maybe, oh, there we go, Julie.
I'll just say part of it. I don't think that there's a simple answer to that either. So I think that that there has been bulbar dysfunction, but I think that it is possible. Parents have an unrealistic expectation sometimes that if a child is treated with a disease-modifying therapy, suddenly they're going to eat, they won't need a G-tube, everything is going to normalize, and that's not the case. So as with any patient who's having bulbar dysfunction or speech or swallowing problems, you go carefully. And so in conjunction with the pulmonologist who will be looking at the sleep studies, the breathing, the ventilation, and with a speech pathologist, so we do swallow studies on patients who have significant bulbar dysfunction. If they're having constant aspiration, then we will not advise that they orally feed. But some of them have gotten a little bit better, and so then you advance with a little bit of thickened feeds, but it's not an overnight sort of process. So I think that it's done as a multidisciplinary team approach to help the child, but again, setting realistic expectations of just because, and we've had patients, families who've said, well, we're not going to put a G-tube in despite the fact the weight is going like this, and this was before we had newborn screening, but weight's going like this, the child's not thriving. It's like, well, we're not going to do that because we're going to treat them with risdiplam or nusinersen, and they're going to be fine and they won't need a G-tube. So G-tubes are removable. Children may advance, but we're still finding out what happens with these patients. That's why we monitor them. So I think it's not a simple answer. I would agree with John.